Assalamu alaikum everyone. My name is Dr. Naseem Akhtar. I am working as Assistant Professor and Head of the Department in the Department of Infectious Diseases at Pakistan Institute of Medical Sciences. My basic qualification is as Medical Specialist and I have done my second fellowship in Infectious Diseases. I have also done my Masters in Public Health. My basic area of interest is not only treating the ailing humanity with various infectious diseases, but also infection prevention and control and antimicrobial stewardship. Today, the topic of my talk is antimicrobial stewardship. So, the objectives of my talk are: what is AMR? What is global burden of antimicrobial resistance? What is antimicrobial stewardship? What is meant by optimal antimicrobial therapy? What are the core elements of antimicrobial stewardship program? To review the etiology of common respiratory tract infections, to treat or not to treat with antibiotics, what is antibiogram, and what is aware classification of antimicrobials. So first of all, I would like to talk about antimicrobial resistance, how it develops. Misuse and overuse of antimicrobials is one of the world's most pressing public health problem, resulting in antimicrobial resistance. It is an urgent global public health threat. What happens is that infectious organisms, they adapt to the antimicrobials designed to kill them, making the drugs ineffective. And the people who are infected with antimicrobial resistant organisms, they are more likely to have longer and more expensive hospital stays and may be more likely to die as a result of an infection. According to a systematic analysis in 2019 on global burden of antimicrobial bacterial resistance, it was found that AMR directly attributes to death of at least 1.27 million people and is associated with nearly 5 million deaths worldwide. It was also found that all-age death rate attributable to resistance was highest in Western Sub-Saharan Africa and was lowest in Australia. In the same survey, it was found that lower respiratory infections accounted for more than 1.5 million deaths associated with resistance, making it the most burdensome infectious syndrome, followed by bloodstream infections, intra-abdominal infections, and urinary tract infections. In the analysis, it was found that 6 leading pathogens for 929,000 attributable deaths to AMR and 3.57 million deaths associated with resistance were in 2019. The common pathogens were E. coli, Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa. Here there are two graphs, and you can see that in the lower half, it is shown that pathogen attributable fraction of AMR deaths which were associated with resistance, and here in this case E. coli, Klebsiella, Acinetobacter followed by Staphylococcus, Streptococcus and Pseudomonas were the most common bugs. Whereas in the upper half of the graph, you can see that it shows pathogens attributable fraction of AMR deaths attributable to resistance were E. coli, Klebsiella followed by Acinetobacter, Staphylococcus, Streptococcus and then Pseudomonas. In the same analysis, it was found that methicillin-resistant Staphylococcus aureus or MRSA caused more than 100,000 deaths attributable to AMR in 2019, and 6 more pathogens caused 50,000 to 100,000 deaths. These included multidrug-resistant tuberculosis, third-generation cephalosporin-resistant E. coli, carbapenem-resistant Acinetobacter baumannii, fluoroquinolone-resistant E. coli, carbapenem-resistant Klebsiella pneumoniae, and third-generation cephalosporin-resistant Klebsiella pneumoniae. So, antibiotic-resistant bacteria cause more than 2.8 million illnesses and at least 35,000 deaths each year in United States. There is a bug which is called Clostridium difficile, which is a bacterium which causes very severe diarrhea due to antibiotic overuse or misuse, which adds to this toll of mortality, resulting in total 3 million infections and 48,000 deaths. If we look at the data from the neighboring countries, we found that in India, 58,000 babies died in 1 year from super-resistant bacterial infections, which are usually passed on from their mothers. In the European Union, antibiotic resistance causes 25,000 deaths per year. In Thailand, antibiotic resistance causes 38,000 deaths every year. Every 45 seconds, a person dies from an antibiotic-resistant infection. And there are estimated 10 million deaths by the year 2050 with only antimicrobial resistance. In this slide, you can see that the burden of deaths via antimicrobial resistant infection is going to be much higher as compared to deaths due to cancer, diabetes, diarrheal illnesses, or even road traffic accidents. Drug-resistant infections are rapidly emerging, compromising our ability to treat even common infections. Rapid spread of superbugs, multi and pan-resistant bacteria not treatable with existing antibiotics. The success of modern medicine in treating infections, conducting surgeries, transplant, and chemotherapies is at risk. Huge economic loss, lower productivity, prolonged hospitalization, hospital stays, and expensive treatments are big challenges. And very important to mention over here is that the clinical pipeline of new antibiotics is dry. New antimicrobials are very urgently needed to combat the challenge of current antimicrobial resistance. Carbapenem-resistant gram-negative bacterial infections are very hard to treat, and we have very limited choices, and that too are not only very costly, they are associated with various side effects. Rampant use can cause side effects and antimicrobial resistance as well. The cost of AMR to national economies and health system is going to be very high. In this slide, you can see that the number of antibiotics which were available in initial years of this era was high, but gradually with the passage of time, as I already mentioned, the number of antibiotics which are currently developed are very low, and we are hardly having any new antibiotics to combat the challenge of antimicrobial resistant bacteria. For common bacterial infections like urinary tract infections, sepsis, sexually transmitted infections, diarrheal diseases, we have observed antimicrobial resistance worldwide. Klebsiella pneumoniae is a common intestinal bacteria, and it can cause life-threatening infections. And it has been noted that carbapenem resistance in Klebsiella pneumoniae spread globally, causing healthcare-associated infections and 50% therapeutic failure. And it is also very important to mention over here that fluoroquinolone resistance to UTI is very, very common. And it is also a common observation that the physicians treat urinary tract infections not only empirically, but also they use fluoroquinolone as a drug of first choice. But the data is otherwise, because the fluoroquinolone resistance is very, very high, and patients have prolonged sufferings because of urinary tract infection, and they end up having complications due to UTI. Colistin is a drug which is a treatment of last resort against resistant Klebsiella pneumoniae. It has also shown increased resistance. In 2019, a new antimicrobial resistance indicator was added in Sustainable Developmental Goal Monitoring Framework that monitors MRSA and E. coli. GLASS collects the surveillance data on resistant strains. Drug-resistant TB causes 0.5 million new cases, and majority are resistant to two most powerful drugs against tuberculosis. The prevalence of XDR Salmonella is also on rise. Antiviral resistance is also an increasing concern, and the resistance has also developed to various antivirals, including antiretroviral drugs. More than 50% infants in Africa are now resistant to antiretroviral therapy. Emergence of drug-resistant parasites poses one of the greatest threats to malaria control as well. Artemisinin-based combination therapies, they have also started to show resistance, and which is very alarming. Drug-resistant fungal infections are also increasing, and they are resulting in various severe and life-threatening infections which are very, very difficult to treat. A huge burden of multi and pan-resistant bacterial infection is there in Pakistan, and it is leading to significant mortality and morbidity, limiting out options for treating common infections. And the common examples are multi-drug resistant gram-negative bacteria, extended spectrum beta-lactamases, New Delhi metallo-beta-lactamases, MDR tuberculosis, methicillin-resistant Staphylococcus aureus infections, and vancomycin-resistant enterococci. This slide is basically emphasizing that how common these infections are there, and in day-to-day practice we are encountering the patients with resistant bacteria. Among them, multi-drug resistant Acinetobacter, multi-drug resistant Pseudomonas, and various antifungal and antiviral resistance has also been observed among very seriously ill patients. So what are the causes of antibiotic resistance? There are various. One of them is overprescription of antibiotics, and misuse and overuse of antibiotic is one of the leading cause of development of antimicrobial resistance among the common bacterial infections. The second cause is patients are not finishing their treatment. Either they are using it for a limited time, or they are using it for a period of time which is beyond their prescribed duration. Overuse Overuse of antibiotics in livestock and fish farming is also contributing a lot to the development of antimicrobial resistance. And another very important aspect is poor infection control practices in the hospitals, in the clinics, and various other areas where patients are being seen. Lack of hygiene and poor sanitations are also contributing towards the development of antimicrobial resistance. And another important thing is that there is lack of new antibiotics which are being developed currently, and therefore it is contributing towards the more challenging environment for treating the serious infections. In this slide, I'm trying to show you that how antimicrobial resistance is transferred from various areas in the environment. So first, you can see in this slide that antibiotics are given to food producing animals, and antibiotics are also used to enhance the productivity of the crops. These animals develop drug resistant bacteria in their gut, and these drug resistant bacteria then reach humans through food, the environment like water, soil or air, or by direct human to animal contact. And once these drug resistant bacteria they enter the human body, they spread to other patients through poor hygiene and unclean facilities, and from there you can see that once the patient attends the hospital or the clinic, they are able to spread this infection not only to the other patient or to the healthcare workers if the infection control practices are not properly adopted. Another mechanism of antibiotic resistance is selection pressure. In this slide you can see that on the extreme left corner you can see that the susceptible bacteria are shown in green color, whereas the resistant bacteria are shown in red color. And once we use antimicrobials to kill the bacteria, or we give even if we give the antibiotics with very broad spectrum, or we use antibiotics for a longer duration of time which is not ideally required for that particular infection, there is a selection pressure created. And you can see that once the antibiotics kill the susceptible bacteria, the resistant bacteria are left behind and they get a chance to grow and multiply, and they dominate the population of bacteria in the gut. These resistant bacteria, they share their antibiotic resistance to the other susceptible bacteria, and on the extreme right corner of the slide you can see that all the susceptible bacteria are now replaced by the resistant bacteria, and this is how the antimicrobial resistance spreads on the basis of selection pressure. This is a very important slide which highlights the importance of development of antimicrobial resistance. Antimicrobial resistance is of two types. One is the inherent resistance and the other is the acquired resistance. The acquired resistance develops very soon, and you can see from this slide that the lower half of the slide shows the date of discovery of the antibiotic, and the upper half of the slide shows the date of resistance identified. And here you can see that in 1928 when the penicillins were discovered, in 1940 the resistance was identified first. So there is a very short span of time in which antibiotic resistance develops, and this is a very common phenomena, and there are certain reasons which are in our hands and we can stop the development of antimicrobial resistance, but there are certain reasons which I already mentioned, that there might be some inherent phenomena going on for mutations developed or adopted by the bacteria. Here we cannot do anything. So the main aim of this antimicrobial stewardship is that what we can do to stop the spread of antimicrobial resistance and to save the life-saving antibiotics for severe life-threatening infections. About 1/2 of antibiotic use is inappropriately prescribed. There are a number of reasons that an antimicrobial prescription may be considered inappropriate. Sometimes this happens that there is an absence of a bacterial infection and the antibiotic has been prescribed for some viral infection. Sometimes there is an absence of an indication for prophylaxis, and broad spectrum agents are used to treat very susceptible bacteria, and this has been a very common practice among various institutes and hospitals. Violation of one of the D's of optimal antimicrobial therapy contributes to the development of antimicrobial resistance, which is, I think, the most important area where we can intervene and stop the spread of antimicrobial resistance. This slide shows the importance of prescribing practices, and it shows that antibiotic prescribing was not supported in 79% of the patients with community acquired pneumonia, 77% of patients with urinary tract infections, 47% of patients who were prescribed fluoroquinolones injudiciously, and 27% of patients were prescribed intravenous antibiotics without any specific indication. So these are the 5 Ds of optimal antimicrobial therapy. So one is drug, number 2 is dose, number 3 delivery, de-escalation and duration. So this highlights the importance of each and every aspect when we prescribe a drug. So I would like to comment on all of them one by one. The first important thing is that whenever we prescribe an antibiotic, this should be according to the specific ailment with which the patient is suffering. It means the drug and bug combination should be very right. As I already mentioned, that if patient is suffering from some other illness and we are prescribing some other antibiotic which is not suitable for that particular infection, that is going to end up not only with prolonged hospital stay but will also end up with poor outcomes in that particular patient. So we have to be very careful, and we must take the history of the patient, examine the patient, and should think about that which drug would be most suitable as an empirical therapy. But before starting a drug or antibiotic, one should set site-specific cultures to pinpoint the diagnosis. The second important thing is dose. The dose should be very, very clearly written on the prescription, and it should be according to the site of infection and according to the bug as well. Delivery means that what is the route of therapy, whether it is IV or oral. De-escalation means that whenever there is a need for switch from IV therapy, that is intravenous therapy, to oral therapy, one should de-escalate. And the second thing is that whenever we use a broad spectrum antibiotic at the initial step, we must switch to a narrow spectrum antibiotic according to the culture report. Patients should be prescribed antibiotics properly for a particular illness, and the duration should be very, very adequate, because some of the infections they need treatment only for 3 to 5 days. There are some serious bloodstream infections which may need therapy for 14 days, and serious and other infections like bone and joint infections, endocarditis, and brain infections may be requiring prolonged duration of treatment. So the duration of therapy matters a lot, because if we stop the treatment earlier on or if we prolong the treatment, both ways can end up with various complications for that particular patient. So antimicrobial resistance has huge negative impact on the health. So if we talk about the excess cost, it results from prolonged hospital stay, and it causes increased burden on the health system. There is cost associated with antibiotic resistance, and we also have to spend money on management of complications. And treatment is with the more expensive drugs if we are not treating the patient according to the specific diagnosis or according to the proper culture report. Resistance can also end up with poor patient outcomes. It can result with adverse drug reactions. Patient can end up with having organ toxicity in the form of hepatic, renal, cardiac, etc. Patient can have superadded infection if we give antibiotics unnecessarily or a prolonged duration of time, and then patient can have longer duration of illness, which can not only affect the quality of life but can also result in increased mortality. And last but not the least is development of antimicrobial resistance, which appears because of misuse or overuse or underuse of antibiotics. The excess cost negates the technological advances in the medical sector. We know that patient undergoes complex surgeries, there are transplants going on, and there are various other costly interventions which are going on because of various illnesses in this modern era. But once we give wrong antibiotic with the wrong dose, with the wrong duration, there will be a technological failure in such cases, and patient will end up with having not only prolonged hospital stay, but it will very badly affect the quality of life for that particular patient. The patients also act as a reservoir of resistant organisms which are passed to the community and other healthcare workers, and there is huge economic impact not only on the individual but also on the society and community as a whole.